Thank you. And I'm going to hand over to Claire. Thank you.
Can you hear me?
Yes.
Okay, it says that my mic is disabled. Anyway, so hi, thank you so much for having us. I'm Claire, and I have the pleasure to present with Sathya today. And let's jump into the presentation. So our presentation is titled Toward Equity in Dementia Care from Measurement to Action. Before starting, I want to make a land acknowledgement. I want to acknowledge that McGill University and University of Ottawa, the universities where we are working, are located on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe nations. Our institutions were built and established with unpaid slave labor of Black and Indigenous people. While we honor and pay homage to this acknowledgement, we understand that as newcomers to the lands, or settlers, we must support these communities and nations in their struggles for decolonization, reparation, land back, emancipation, and healing, while developing our knowledge of the immense pain and trauma of intergenerational struggles. Few words on our team. So we are the Équipe Rosa in French, the Rosa team, which is the team on the research and organization of healthcare services for Alzheimer's, Recherche en Organisation des Services sur l'Alzheimer, which was created by Howard Bergman and Isabelle Vedel, and which we are with Sathya currently leading one of the component that's focusing on equity. The aim of our team is to provide evidence to decision makers to improve the care trajectories and better the care offered to persons with dementia and their care partners. We've been collaborating with the Ministry of Health in Quebec for a long time. Howard Bergman was the person who wrote the Quebec Alzheimer's Plan, so the first Alzheimer's dementia policy in Quebec. Howard and Isabelle also wrote a report to the Canadian Academy of Science that informed the federal strategy, so the national strategy, Canadian strategy on dementia care. And then Howard did write the ministerial policy for the Quebec plan in 2025, and Isabelle is responsible of the implementation and evaluation of this policy. So it's just to exemplify that we have strong ties with the Ministry of Health, especially in Quebec for now. We are developing them in Ontario, where Sathya is located. And the principle of our team and how the method and approaches we use a participatory approach where we involve persons living with dementia, caregiver, care partners, as well as clinicians and the decision makers. So for decision makers, the Ministry of Health, especially in Quebec, but also, as I shown you, at other levels of jurisdiction. We adopt an equity lens and an intersectional approach. So we acknowledge that there are intersecting systems of power that shape the equity and inequities you live in. For now, with Sathya, in our initial research project, we focused on socioeconomic status, and now we are expanding on racialization, but we also had some works on gender, on rurality, and on language. We use mixed method, so most of our studies are structured the same way. We have one quantitative component where we measure inequities, or we measure differences, and then we reflect on whether they represent inequities in health administrative database. So we access health administrative database where we see through billing codes, hospital visits, emergency department visits, physician visits, as well as medications. And from that, and you will see some of our work with health administrative database later on, we try to measure differences in the care that people receive. And then we have a qualitative component to our studies where we explore the lived experiences of persons living with dementia or of care partners and caregivers, but also the lived experiences of healthcare professionals. So, for example, regarding equity, and I'm not going to go further because actually Sathya is going to present you that later. And then in most of our studies, we do assemble these quantitative and qualitative data to use the power of numbers and the power of stories, and then to generate and co-generate recommendation with interested parties at all levels, from persons with the disease to policymakers. Mini note on what is it, Canada. So we do have 13 provinces and territories that are represented here that are actually independent systems. So you're very happy when you start mastering and understanding one system and understanding their health administrative database. And then when you go to another province, you actually have to learn a lot again, because these systems have been built independently. So they have many little differences. However, they are all under the Canadian Health Act, which, among other principles, has the principles of accessibility and comprehensiveness, which says that we should have access to the healthcare system and that the services offered should be comprehensive. However, well, you will see that accessibility is a work in progress, and you will also see that comprehensiveness has different understanding. And for example, me coming from France, I was extremely surprised that medications are not within the comprehensive healthcare system. So medication are not reimbursed by the public system systematically. There are many private organizations and anyway, so it's much more complex than a universal, accessible, and comprehensive system. There are things that are included in what is comprehensive and things that are out, including medications, including psychologist session, including used to not have dental care, was just added, things like that. And as I said, we do have health administrative databases where billings generate data that we can use for research. So why are we interested in equity in dementia care? It's not the right group to ask this question, because I guess you are all convinced that is extremely a hot topic and we should care for that. Just going to tell you some of the points why we think it's important. So first, because persons with dementia are at a disproportionate risk of inequities because of the dementia risk factors. So as you know, as per the Lancet Commission, many of the risk factors of dementia are actually also associated with socioeconomic status, experiences of discrimination, racialization, gender, and so because of that, the person who have dementia are more at risk of inequities. So, for example, regarding socioeconomic status, the relative risk to have dementia is higher in lower socioeconomic status strata. Then also the fact that the care trajectory is complex and that each stages of the disease, you require a different mix of healthcare professional to care for you, makes that actually these are all opportunities to not receive the care you need. So this complex trajectory add opportunities to have suboptimal care and have unmet needs. And finally, the disease by itself make it harder to being heard. Navigating the healthcare system is more complex. Having one's rights and needs heard is difficult, and thus obtaining appropriate services. So in the literature, there are already evidence on the link of a worst outcome and lower socioeconomic status, like higher mortality, more severe stage at diagnosis, younger age at death, less access to specialists, more emergency room use, less dementia medication prescribed, or more long-term care admissions. In general, there is a lot of underdiagnosis in dementia. Up to 2/3 of people would not have a diagnosis. And this might be exacerbated this is exacerbated for lower socioeconomic status people. What was known in Quebec, in Canada, before we started our work, actually not so much. And in addition, there was no objective in the Canadian dementia strategy to reduce inequities. So we know that when we do a population-wide intervention, the problem is that the better off, the wealthier, the one that have better resources, literacy, money, network, will pick up the innovation better. So actually, if we implement a population-wide intervention, we are at risk to exacerbate inequities because some population will get it and benefit from it faster. And so not having a targeted strategy to reduce inequities is actually at risk of exacerbating inequities. So that's where we arrived to first to measure inequities in dementia care in the context of Canada. So we wanted to see whether these dementia, poor outcome, lower socioeconomic status were linked to inequalities in service use and a higher level of underdiagnosis. So for people with dementia, do some of the poor outcomes associated with lower socioeconomic status manifest inequalities in service use and a higher level of underdiagnosis? And as I said, the first studies we did were focused on socioeconomic status. So here is one of our study. We looked at the health administrative databases that was in Quebec, and we had repeated yearly cohorts. So every year on the 1st of March, we included everyone that had an incident dementia in Quebec and followed them up for 1 year. We had around 200,000 people. We measured 27 care and health service use and mortality indicators. And we stratified people according to their place of residence. So for each place of residence, we can link people to their census dissemination area information. The census dissemination area is the tiniest geographical section that exists in Canada. And so and it encompasses around 500 to 700 people. And so each person was stratified according to this index of socioeconomic status, which has 5 levels and is a composite measure of level of education, employment, income, and it's thus an ecological variable. And then we looked at the graphics to see the differences. So here you see all the graphs are structured the same. So by year, the year of the cohort, you see the age standardized rate. The persons living in an area of lowest socioeconomic status are the lighter blue, and the person living in highest socioeconomic status neighborhood are the darker blue. So what you can see is that over the 17th year of our study, a person living in lowest socioeconomic neighborhood had there were more person that lived in lower socioeconomic status neighborhood that had at least one emergency department visit during the year of diagnosis, with the blue lines not crossing each other. Same when you live in a lower socioeconomic neighborhood, you're more at risk to have at least one hospitalization, and you are more at risk to receive at least one potentially inappropriate medication, either a benzodiazepine or an antipsychotic. Then you're also more at risk to be admitted during your year of diagnosis in long-term care, or to die within the year of your diagnosis. On the contrary, you're less at risk, you have less risk or chance to see a cognition specialist during the year of your diagnosis, with the light blue line that is not crossing the dark blue line, and they are more for the higher socioeconomic status neighborhood. For some indicators, there were no difference. For example, same number of visits in primary care and same number of medication specific to dementia, anticholinesterase, and memantine. Then we looked at underdiagnosis. So we took each cohort. So each year you have the people that you included as the incident cases of dementia in your repeated cohort. And we looked at where were they living, and where they're living in this according to the socioeconomic status of their neighborhood. And what we saw is that even if there is some kind of a trend on average to have a bit more people living in the most deprived area over the less deprived area, compared to what we would have expected from the literature, this difference is not enough. So because we said that most of the risk factors of dementia are associated with socioeconomic status, if we make some inference that people living in lower socioeconomic status neighborhood do have a lower socioeconomic status themselves, then they should have higher incidence of dementia. And what we see here is that even though there are little slight differences, that is well less than what would be expected from what we see in the literature. So to wrap up, we found that there was not enough difference in the incidence across socioeconomic status. And so we were asking whether there was a higher underdiagnosis in lower socioeconomic neighborhood. And then we saw for most of the 25 indicators, differences in service use according to socioeconomic status of the area of residence in a healthcare system that is publicly administered, universal, comprehensive, and accessible. So with higher hospital use in lower socioeconomic neighborhood, higher prescription of potentially inappropriate medications, higher specialist visits in higher socioeconomic status neighborhood, and higher admission to long-term care and mortality in lower socioeconomic status neighborhood. So we found these socioeconomic differences for most indicators, which may signal inequities. So indeed, if we say during the year of diagnosis, persons living in lower socioeconomic status neighborhood had more admissions, had more emergency department visits, had more mortality, more long-term care admission. All of that might mean that they are actually sicker, which would make sense according to the literature and what we know, where actually health status is associated with socioeconomic status. But what we see, well, first, that is an inequity, like, and then what we see also is that these people that are sicker and that receive more potentially inappropriate medication see less often specialists. And in Canada, the strategy is that we take care of most cases of dementia in primary care. So the idea is that for the non-complex cases, everything should be cared for in primary care by the multidisciplinary team. But here, you know, there is like some dissonance between having more medication that might have been prescribed for psychological and behavioral and psychological symptoms of dementia, and at the same time having less visit to the specialist who can help in these complex cases. And then we also have the impression that there is underdiagnosis in a lower socioeconomic neighborhood. So among the limits, the fact that these are ecological variables, so we are speaking about the neighborhood effect, and we should be aware of not doing ecological fallacy in attributing it to individual variables. And then also emphasizing that it's not because there are differences that it's directly an inequity. And so that's why we, after looking at our results, we discuss with stakeholders to to think, okay, are these differences related to inequities? What I just did. So in conclusion, poor service use, greater underdiagnosis in persons living in more materially deprived area. And we want to look in our future work, which Sathya is going to present to you, and measure more and develop intervention to prevent these inequities. Sathya?
All right, thank you, Claire. Okay, so over the next few slides or in the rest of this presentation, I'll just go over some of the approaches that we're adopting to extend the work that Claire just presented. Next slide, please. So just last year, we were funded by the national funding agency here, CIHR, to lead this team that is basically advancing equity in dementia care in Canada, an intersectional and participatory approach. So this is, as Claire mentioned, an extension of the work that the ROSA team has been doing over the last decade, and led by Claire, myself, and Ngozi Iroanya, who is our caregiver partner. So what Claire described to you up to now, here you see the Canadian map again. So what Claire described to you earlier is focused on Quebec, and a big part of what we want to do over the next 5 years is to extend this work to other parts of Canada, so to the other healthcare systems within Canada, including Ontario, British Columbia, and Alberta out west. And we have a couple of other provinces that will also, be included in the process. But, as Claire mentioned, every province is a different healthcare system. So it's a substantive amount of work to, learn that and figure out how to do these kinds of analyses as they're applicable to the context. So we're starting with these four, and then slowly, hopefully extending over time to the others and sharing the learnings. So in terms of what we plan to do, listed there is our first step is to really catalog databases. So we want to understand where data is available that would allow us to look at the types of questions we're interested in looking at. So inequities are measured or sometimes not, or equity variables are sometimes measured and sometimes not in the databases, including health administrative data sets, but also cohorts with potential for linkage to health administrative database. So really our first step is to do an inventory of what's possible across Canada and make that catalog accessible to researchers, really to promote equity research in other groups as well. The second phase is measuring inequity, so using the existing data to document inequities, extending again the work that Claire described, so socioeconomic status, but extending to other equity variables that I'll go into. And then finally, looking at priorities for practice and policy changes. And I'll talk a little bit more about that in the next slides. So as I mentioned, we're working with 6 provinces in our team. We've got a panel of 12 people with lived experience whom we consult as we develop our research. We've got 8 international experts representing 5 different countries. Our team is comprised of 7 co-principal investigators and 42 co-investigators, so a very large, diverse team of experts. We work closely with community and professional organizations to inform the types of questions, to interpret the results, as well as knowledge translation partners. As Claire mentioned, there's a very close partnership with the Quebec Health Ministry and now with the Ontario Health Ministry. So this is an important part of ensuring that what we're doing is relevant to the current day policy, but also will then be considered in future policies. And then we've got a couple of national organizations as well. PHAC is public health, the Canadian Agency for Public Health. And CIHI basically is an organization organization that produces data and results related to data across the country. So there is some work that happens at the national level, and then, we're focusing within that at the provincial levels. Next slide, please. So I think Claire has covered a bit of this, but I'll just go over quickly in terms of the methods we're planning to use. We do favor a mixed methods approach, so looking at lived experiences, looking at large health administrative databases and other sources of data, and then integrating those to better understand the experiences. In terms of quantitative methods, again, extending on the work that's been previously done by the team, we want to introduce advanced methods such as IMEDA, which is basically a multi-level analysis, but looking at specifically designed to look at intersectionality. So rather than looking at these individual equity variables or equity identities, we want to kind of consider the experience of people with multiple identities that might put them at a position of inequity. And of course, we have multi-provincial qualitative studies on lived experiences. In terms of the approaches, we do, invest a lot in engagement, as I mentioned, from different levels of decision makers to people with lived experience and organizations that serve the community. We focus on health equity, as I think very clearly mentioned up to now, and intersectionality, and we do EDI-oriented training. So training is, of course, an integral part of what we do. Trainees contribute very heavily to our work, and there's an important part of this, which is training the next generation of researchers to be able to explore these areas further. Next slide, please. So the next part, or I guess the last part of my presentation, will focus on, what we're calling measurement to action. So really work that we did with a community organization to inform and better understand inequities in the system and how they are impacted by these inequities. So as Claire mentioned earlier, the new Quebec Alzheimer's ministerial policy was released almost just a year ago, so in February 2025, and it draws on the Quebec Alzheimer's Plan of 2009. And, as Claire mentioned previously, our team members, Dr. Vidal and Dr. Bergman, were involved in drafting the policy and are part of the implementation and evaluation. So the policy has 5 axes that address different social aspects of dementia. And the third one, which is really the focus of our work, is taking into account the diversity of people and their social determinants to reduce inequities. So this is set as an axis of the policy. And in light of this new policy, our team decided to engage with equity-seeking community to discuss how the policy might benefit them or actually might fail to meet their needs. And so we use that consultation to generate recommendations that reduce barriers along the dementia journey. So what I want to do, over the next few slides is just describe the process we used to consult with them, and then happy to have further discussion. So the objective was to co-generate implementable recommendations to make the Quebec Alzheimer policy more equitable, to reduce barriers faced by equity-seeking groups. So we really wanted to respond to this third axis of the policy, and do that with a policy brief. So we partnered with the African Canadian Development and Prevention Network, which is so I'll refer to them as ACDPN. They're a community organization that serves Black English-speaking community in Montreal. And I mention English-speaking community just as a reminder that this is a context where French is the primary language. So English speakers are a minority. And when we're talking about the Black community, then we're talking about people who are minoritized by their racialization as well as their language. And yeah, so that's the context. So in terms of method, so we held a deliberative dialogue, which is really, and I think, you know, some of the work done by this group as well has used similar approaches. So what we had was a meeting that was structured and facilitated with people with different roles and lived experiences. And so the idea is that, you know, we're blending together research evidence and real world context, aiming to produce a shared understanding and practical next steps for policy and programs. And so in terms of the timeline, as I mentioned, the Quebec Alzheimer's policy was released in February 2025. And so in May 2025, we began co-designing activities for our deliberative dialogues in collaboration with the ACDPN and the Alzheimer's Societies of Montreal and Laval, and the Federation of Alzheimer's Societies. So, you know, multiple meetings with these organizations to decide how we were going to structure the meeting with the community organization. And then in June, we held our first deliberative dialogue, which began with a short lay-friendly evidence segment on modifiable risk factors. So you see that poster on the side that was developed for this purpose. It's on the ideal care pathway. So, you know, kind of going through what would be what, you know, could be described as the ideal pathway for someone who to receive a dementia diagnosis and then go through the healthcare system. So we had a case vignette of a person we refer to as Mrs. Miller to anchor the participants' experience in the dementia care trajectory. So we tell the story of how Mrs. Miller receives a diagnosis and then goes through the trajectory of care. And so at this meeting, we had, in the previous pictures you saw, we had 11 participants, all of whom were women care partners of persons with dementia. And so following this deliberative dialogue, we conducted a thematic analysis of the key issues that were raised during the meeting. So we identified key issues and then shared these with the Alzheimer's Society of Montreal and the Federation of Quebec Alzheimer's Societies, who provided their own recommendations. So in discussion with the themes that arose from the conversations, we were able to you know, gather this information and come up with a comprehensive list of recommendations that combine the input of community members, of the organizations that are meant to serve these community members, and as well our research team. And so with that, we went into a second deliberative dialogue. So we went back to ACDPN and provided them. So our goal was to have community members generate recommendations that they viewed as their top priorities that we could then present to the Ministry of Health and Social Services. So we opened that meeting with an infographic that you see again on this slide on the right. And the infographic summarizes the themes of the first session so that participants could use those to build on them when forming their recommendations. So this happened in August of 2025, and currently we are we're integrating the recommendations that were generated at that meeting into a policy brief, which will then be shared back with the community members for final feedback. And we plan to present this brief to the Ministry of Health and Social Services. And this presentation will include a community representative. So just going then to, in terms of you know, an overview of our approach. We had 2 lunches, and I want to mention that, you know, even in planning that, I mentioned earlier, you know, we did have multiple discussions with the community organization, and, you know, to decide what the format should be, what the venue should be, what the food should be. You know, all of that was really done in consultation with leaders of that group. We generated 6 recommendations, which will be presented as a policy brief as well as a publication. And we involved 11 community members. Next slide. And so just in terms of, you know, some of the takeaways of our approach and the feasibility of the work we did here, this was really built on a long-term relationship that had already been established between our research team and the community organization, which allowed us to really kind of work with them, develop an approach and implement it, and continually have conversations and feedback to decide, you know, what the next step would look like. We worked with a structured organization, so that was helpful. ACDPN has been in place for some time. They've got, you know, leaders within that organization who had capacity and recognized work on dementia as a priority for their community organization. So we built really on that. Of course, it requires work, so it required, you know, a lot of time and work from members of our research team as well. But you know, at this stage, you know, things have moved forward in terms of the way, you know, the goals of the project, and we do envision, we've got very positive feedback and interest in future collaborations with ACDPN and expanding that potentially to other organizations as well. So yeah, so just want to end with a thank you and recognizing, as I mentioned, it required a lot of hard work from our team members. You see Zaina and Sanjna, who put a lot of time into those beautiful graphics that you saw that were presented to the community organizations, and then, you know, facilitating those conversations and summarizing their perspectives. So we will end there and recognize also multiple sources of funding that allowed us to do this work. Thank you.
Thank you very much for those presentations. It sounds very much like a lot of the work that we've been doing on inequalities and your deliberative dialogues, where we've been having focus groups around similar themes. I don't know if we have any questions. There's nothing in the chat. I'm hoping that I haven't set it so people can't chat. But if anybody does have a question and would like to raise the hand, we could address it that way. Can't see any hands raising. Okay. Well, I think unless you have anything. Oh, here we go, Mark. Let me unmute. Okay. Hang on, Mark. You're still on mute.
I'm a general medical practitioner, so family doctor and professor of that in here in Liverpool, and work with Clarissa and colleagues. So I wondered if you'd noticed any impacts of the inequalities in the types of care and the approaches that people receive in terms of their care packages and their care plans. So I noticed that one of the things you were saying, sorry, I missed the beginning of the talk, was about medication, and certainly there's an issue in the UK about the types of medication that people living with dementia are prescribed, and there's a lot of precautions around antipsychotics, for example. What's the state of that in Canada? Is there a move to reduce the amount of prescriptions that are there to sedate people and prevent them being awake or wandering or whatever, and to move more towards other types of intervention to reduce that type of behaviour.
Yes.
And is there, as I suspect there is in the UK, a difference in the ability to access and get that, what could argue more intensive, more complex care than prescribing somebody a medication might be?
Yes, for sure. Like we have a big challenge with potentially inappropriate medications. We have another study that showed that persons with dementia have, over all these years, like over all the 15 last years, have like 5 times more antipsychotics prescribed than older adults of the same age and sex. We have a very high level of potentially inappropriate medications prescribed. We have several initiatives regarding deprescribing. However, are these initiatives comprehensive enough, and are the resources associated with this initiative enough? That's an excellent question, because for example, like home care access is a challenge. Currently, we don't have data on home care disparities across the home care offering and home care use disparities across the province. We don't have this data. However, as a geriatrician myself, I do see like there are some regions, like you say to social workers the postal code of the person, and they tell you like just from the postal code whether the discharge from hospital will be complex. So I guess there are like clearly disparities in the offerings. And yes, how do you, like telling to family physician to deprescribe medication when you don't add services, support, respite care, home care services, caregiver support, is actually strange. Like, how do you want people to be able to deprescribe if you don't give them the full package of resources and support that could allow you to deprescribe? So we have several initiatives. We have some initiative in long-term care where we also have a lot of potentially inappropriate medication. But yes, it's also a challenge.
Okay, I've got a question here from the chat, and it says, your mention of 11 members of the community being involved and all female, what were your criteria for choosing, or was it all voluntary involvements? And will your further research expand co-creation and participation? That was from Catherine.
Sure, I can take that. Yeah, so it was voluntary. We had, ACDPN put out the call, and it was the community members who decided they wanted to participate. We didn't actually anticipate 11, so it was slightly more than we actually expected. So we were very happy with the level of participation and their willingness to come back for a second meeting as well. In terms of expanding, we do expect, in terms of, this policy brief will be based on that work. But I think over time, we do expect to connect with other communities. We have already started working with other communities on other types of initiatives in terms of engaging the community to develop awareness of campaigns around dementia. So those are our initial establishing of relationships with these other communities that will hopefully lead to the possibility of further deliberative dialogues like the one we did there. Yeah, thank you.
Okay, great. Thank you. Right, there's no other questions in the chat, so I'm assuming we have no other questions. Anybody? Okay,
and perhaps you could.
We've had some. It says, I guess this about action impact given you have been able to describe the inequalities. What next? How specific is the policy briefing? Is it specific and actionable in what it recommends?
Yeah, that's a good question. So we're still in the process of finalizing the recommendations, which is why, we weren't necessarily ready to share. Like, we would like to take them back to the community members and finalize. But you know, the types of things that came up were really around you know, examples like empowering the community to prevent avoidable long-term care admissions, or specific initiatives to increase awareness around dementia and decrease stigma around dementia. There's also navigating the care system, so having more a caseworker to support in navigating a system where there's a sense of you know, there is discrimination, or there is, you know, a lack of understanding of the person with lived experience. So there are, you know, I think whereas the policy right now is fairly broad, I think what's been brought forth by the community in terms of recommendations really kind of addresses that third axis I mentioned, but does provide kind of very specific potential interventions. Claire, did you want to? Yeah.
Yes, perhaps. So, you know, like whether the intervention are actionable or not depends a lot on political will. So, for example, you know, like we're working with Isabelle Veda, we're working on the implementation strategy of the plan. We know that there will be a public awareness campaign. So in the near future. So, you know, us arriving with the work we have already done with 3 communities where we have worked with communities where they have produced their own videos, like they have worked on their own stigma, own ideas about dementia. Like, for example, in my community, each time we hear dementia, we are frightened that they will take my loved one and put them in a long-term care. So, you know, if that's the main concern of the community, like they have produced videos around that. Or when we speak about dementia, we hear mental health disease, and that's extremely stigmatized in my community. So our reflex is like to hide the person, like who wants to see you like that, or things like that, you know. And so we've been working with 3 community organizations on producing these videos. So in an ideal world, we have the impression that coming to the Ministry of Health and telling them, we've done this work, communities have told us that not seeing themselves represented makes them not aware that they are concerned, that's an issue that's touched them. For example, a very good verbatim that we heard during the first session was, because the vaccine for shingles is the advertisement for the vaccine is only featuring white people. The ladies were telling us we were not aware that Black people could get shingles, so we did not feel it was like directed to us. So you know, like, so us coming with the backup of Isabelle Veda, with like working on the implementation of the plan, stating that we have already done this work, then showing the Ministry of Health that we have collaborated in Australia where they created, I think, like 20 different dementia awareness campaigns according to each language and community, and assumptions, of course, could be implementable. But what will happen in the next month and years, you know, we just lost our prime minister. So, you know, like it's and then I think there is another thing that we reflected on with Sathya, was that, you know, like on the day we did we co-generated the recommendation, we were super excited, like the world was ours. We were with the women, we had like this 50 recommendation. We said to them, okay, if you can only say 5 things to the Ministry of Health, what do you want to tell them? And so we were merging recommendation, like there was like such a cool energy. But then when we looked at one of the recommendation months after, that was community-led services and care. And, you know, we were writing that to the Ministry of Health, and suddenly we were like, you know, like the Ministry of Health is currently privatizing services, is cutting enough of money. If a community organization is asking for leading their own services, we don't want the Ministry of Health to hear we don't have anything to do for them. which, you know, so we are really reflecting now on looking at these 6 recommendations, and actually we're going to see the women again to speak about unintended side effect of their recommendation. And we want to discuss them with them and see whether they want to change the wording, because yes, that's that. Voila, is the political will willing to implement the recommendation is something? Is the political agenda also aligned with what we propose? And also, like, are there side and unintended consequences we should reflect on before presenting that?
That we've got another question added on here that's asking, I think I can answer that one, whether recommendations following conversations with the community members. Well, you've said that was all co-produced, wasn't it? And then Mark's added the link and said, are you aware of the Dementia Inequalities model that Dr. Giebel published last year? And that was something that we used in some work that we were doing. And there's one more question from Joan, and it's back to the talk about the medication. Is overprescribing associated with inadequate levels or ratio of staff to residents and inadequate training of staff and not knowing how to deal with differential diagnoses within care settings? Is that something that...
So in this study, we focused on persons that don't live in long-term care, including because in health administrative databases, you see very different things according to billing mechanism. So if you look at the 2 populations with the same study and the same indicators, you're going to underestimate a lot of things for people living long-term care because these are different billing mechanisms. So you don't see as much in the health administrative databases. So for now we're focusing on the community dwelling population. Another reason for that is that, as you saw, most of our indicators, equity stratifiers, are at the neighborhood level. And these indicators are not validated for people in long-term care because they have been moved there. And so, for example, the material deprivation index that we use as an indicator of socioeconomic status, that's only validated for a person living where they used to live, like not after moving to long-term care. In the next studies we're conducting, we're also adding a racialization indicator. So we look at the census, the Canadian census, and the answer to the question, do you consider yourself as belonging to a visible minority? So the census is currently revising this question and moving toward the wording of racialization. But so the idea is, do you identify as racialized? And then, you know, to have some kind, an indicator that's going to stratify the neighborhood according to the proportion of people that identify as racialized. So in our next studies, we will look at the intersection of racialization, proportion of people that identify as racialized, or racialization of the neighborhood, and socioeconomic status on the neighborhood. And we aim also to integrate the language variable, as language is extremely important in Quebec. A lot of political, a lot of battle actually under around language. So these are also areas we want to explore.
Okay. Right, well, thank you very much. I hope everybody's found that as interesting as I have, and we are really up to time now. So I would just once again like to thank you for your time in sharing your research with us, and I shall stop the recording, and thank you very much.
Thank you very much.
Thank you.